There we go. So with that, I need to, oh, sorry, I need to share this. Everybody see the screen? Yeah, hopefully. Okay, so so this is really just a bird's eye view. I'm going to try to go pretty quickly. Most of it is kind of fun history stuff, but I really want to get to the process mapping so you guys have an opportunity, and you will be broken out into groups again for that. And we'll do this week, and we'll do it next week too. So we don't have a much rush. If we don't get done this week, we'll move it into next week as well. And that's it. That comprises our last 2 weeks. But I just wanted you guys to have that. So this is, again, this should be kind of a repeat. Has everybody heard of Donald Berwick and the Triple Aim? Raise your hand if you have not heard of Don Berwick and the Triple Aim. Nobody has? Anybody? Has anybody heard of Don Berwick and the Triple Aim? You haven't done that in 641 or any? No? Okay, so Don Berwick is, I like the little X. So Don Berwick and the Triple Aim are kind of where we get the whole concept in policy of the value equation, or what we understand to be the value equation. And this is a classic example of evidence informing policy. So research informing policy. Don Berwick is one of the fathers, if you will, of quality outcomes. So Don Abedian really informed the research on structure, process, and outcome. And Don Berwick really picked up that mantle and kept going. So Don Berwick is now the founder and CEO or president or something of the Institute for Healthcare Improvement or something like that. Have you guys heard of IHI? No? Okay. So yeah. Yes? Okay, so there's a little bit. And so he indicated that the true goal of the modern healthcare delivery system, or the healthcare delivery system, just as Don Abedian conceptualized it, and the seminal report, which he also had a part in writing, of crossing the quality chasm. Have you guys heard of that? The Institute of Medicine crossing the quality chasm for high quality healthcare? Yes. Okay, good. I was like, wait a second, this should be review.
Yeah, we did it in 641.
Okay, good. It's no problem if it's not review. We'll just review it extra little longer. So the Institute of Medicine, which is now called the National Academy of Science, Engineering, and Medicine, gave 6 dimensions for high quality care. And these were what I'll go on and on about: SEPTI, which is safety, safe, equitable, patient-centered, timely, efficient, and effective healthcare, right? So these are all elements that even within themselves have many constructs, many publications. And so Don Berwick called this is the triple aim of healthcare, which is taking all of these, right? So that's care, that falls under care, and improving the experience of care. And then he also said, but we also need to look at the context of care. So that was health. He called it improving the health of populations, right? So it wasn't just within healthcare delivery, but the fact that people that are sick also go out into the population, and people in the population, we want to mitigate the impact of the illness that they experience. And finally, and foremost, was cost. And so cost was reducing the per capita cost of healthcare. So how do we obtain the greatest value, so the greatest improvements in the experience of care, in the overall health of the population, while still maintaining the lowest cost? That was the triple aim. And just to make it more confusing, he's recently come out with the quadruple aim, which is thinking about the providers. So you guys, so the clinicians, the administrators, the doctors, the system, right? So thinking about the health of systems as well. But we won't go into that. We'll just leave it at triple, okay? And you can read these, and I can put these up. Actually, it's funny because I usually give you guys these readings as alternatives, but because they're usually reviews. So I'll make sure to put them up as alternatives, just so you have them for reference. But the whole premise is that this is all about balance and alignment. So it's an alignment with our understanding of population health, patient care, and costs. And so this is the idea behind quality. So in and of itself, the concept of quality was how we, excuse me, well, just read it. How we perceive desired health outcomes to be aligned with what is the best health outcome possible. And so when we look at current professional knowledge, that refers to evidence. But there is a caveat to that, right? Can anybody guess what that caveat might be? Or there's a downside, if you will.
You don't always have evidence.
That's definitely one. Okay, so there's two caveats. There's two caveats. But yes, so, and recently, because of people's access to information and therefore misinformation, is that you don't always have evidence. And that's a clinician speaking. So I can imagine you have some experiences with that. But the other one is overutilization. So there's the potential for overutilization of evidence-based care. And does anybody know what that means, overutilization? Has anybody heard of overutilization of care? You can
Like,
get at it.
oh, sorry.
No, it's okay.
Like people are going to the doctor just to go to the doctor to like confirm, or like overutilizing the system, or
You're getting there. Yes, you're in the zone.
Yeah, so like I know at Kaiser we had a program where people were overutilizing the ER for primary care visits. So they were trying to slash that down by creating more primary care opportunities for them.
Okay, excellent.
Yeah.
So in some cases, it's due to a disparity, so that there's a lack of access, right? That's not typically overutilization. It is overutilization in the sense that more people are using the ED than they would like. But often there's usually a barrier, a cost barrier, a time barrier, things like that.
Yeah.
Okay, so that's another really good one. What else do you have, Talat? I think I saw you trying to.
Yeah, just the overall mentality of people that if they have healthcare insurance, then they just want to go and see the doctor.
Okay, yes, that's getting much closer as well. So the idea too is to use the maximum technology possible when that may not necessarily be the case. So for example, using a surgical intervention when maybe physical therapy should be in order first, or so the desire to use the latest technology because it is evidence-based when it may or may not be the most appropriate for the long term is another one, because we have insurance in some cases, or because we need reassurance in other cases. So, or because we have that access. So that is the flip side of the coin. But make sure you contextualize it within the context of access disparities. So that's something that we often can overlook is like, wait, are these people truly overutilizing, or do they just have nowhere else to go? And then we need to address that as well, right? So we need to make sure that we're looking at both sides of the coin. So I'm going to run through this pretty quickly. I think it's super valuable because I feel like if we don't learn from our history, then we're going to miss out. I don't know how much of this you've seen or how much of it is reviewed, so I'll go pretty quickly. But I just want you to recognize that quality metrics and quality standards have been a huge part of healthcare delivery for a very long time. And healthcare is one of the most regulated fields, and that can be good and bad too. A lot of people like that. A lot of people have a real problem with that or are bothered by that because it does feel like it slows our ability to provide care. But in fact, it also does contribute to a very safe environment. However, there are historical antecedents that have also contributed to inequities due to this under the umbrella of quality. So you have to definitely keep that in mind. So I'll just go quickly. Probably one of the most important was in 1951 was the establishment of the Joint Commission. It was originally called JCAHO, Joint Commission on the Accreditation of Hospitals. Now it's just known as the Joint Commission. If you haven't heard of that, you need to know this because it's very important for you to understand. How many of you have ever interacted with the Joint Commission and know what the Joint Commission is? So hospitals essentially cannot obtain full reimbursement for services if they are not Joint Commission accredited. In particular, this applies to Medicare and Medicaid reimbursement, which is the top funder of pretty much every hospital in the United States. Hospital revenue is largely funded by Medicare and and Medicare revenue, really, more than Medicaid. And then a big chunk is also obviously private payer. But it is one of the top, I'm trying to think of how to say it without telling you. I'll just tell you, it's one of the top ways that a hospital demonstrates legitimacy. So if we think back to institutional theory, because it's an isomorphic pressure, right? So there's no legal requirement to have it. So it's not a, I'm blanking on it too, but it's a normative isomorphism, right? So everybody else, it's a norm, right? Everybody else is doing it, so I need to, so I can be legitimate. So that's a really important accreditation for hospitals. There are many more accreditations, mind you, but this is one that we actually use in research a lot to demonstrate that this hospital has a high legitimacy. It's a very legitimate hospital. So if you look over time, there have been other improvements in quality and performance. Donna Bedian's structure, process, outcome that I keep talking about since the beginning of the course is 1965, very similar to Medicare. And we keep going. So I'll just give you those dates for now. But so let me see here, some definitions. What we're going to talk about today is quality improvement versus quality assurance. What I want you to realize is two things that really bug me about management is one, in management, there are many, many terms that you're going to get into. So I want you to recognize that what you've learned, the theoretical components, theoretical processes are the most important things because you're going to see these patterns often. However, they're going to be named many, many different things. So we're going to talk about quality improvement today. We're going to talk about process improvement. And you may or may not have heard of continuous quality improvement. How many of you have heard of continuous quality improvement? It is the same thing. But essentially the idea, it's all down to a Shewhart cycle, which you're about to meet the Shewhart cycle in just a second. Has anybody heard of the Shewhart cycle yet? So that is the core premise of everything you know about continuous quality improvement, total quality management, Lean Six Sigma, QI, PI, TQM. Sorry, the word soup grows every year, so I can't keep track of it all. But it drives me crazy because I know a lot of students get frustrated, like, do I need to know all of these acronyms? No, you don't. Because depending on your hospital is going to engage in a certain thing. You're going to have, there's Scripps has value, is it Scripps? No, Sharp. Which one has value for design? Value by design. That's their thing.
I think Sharp. I think it's Sharp.
Yeah. So, which is great. It's a great, learning, like how do you say, a great slogan for the hospital, right? If you've seen one, you've seen one. So I don't want you to focus so much on the names. I want you to focus on the meaning. And I want you to focus on what it does. Because at the end of the day, it's all continuous quality improvement. It's all a feedback loop, right? That you're just doing it over and over and over again. All right, I see some chats. Give me 1 second. Okay, so moving on. And I'm trying to see if I don't have the word soup here. I thought I was going to give it to you. Maybe I have it further on. But how many of you have heard of quality improvement versus quality assurance? So those are used interchangeably often, especially in management. But researchers supposedly are like, no, we don't do quality assurance. We do quality improvement. Quality assurance has a negative connotation because it's seen as something that's sort of negative and external, and it's sort of reactive to some kind of problem. Whereas quality improvement, remember, we saw it as perspective. Remember what triggers or what causes quality improvement? You recall from our previous slides. So the way that we look at quality improvement in terms of evidence-based management is structure, process, outcome, right? So you remember this? And you remember Donna Bedian?
Yeah, we did.
We did say we remember this. Okay. I'm going to just jump through here. Okay. And traditionally, when we were doing management, when we were like the old way of managing and thinking about quality was quality assurance. Sorry, I'm trying to rush and cut at the same time and it's not working well. But traditionally, the concept was quality assurance. Think the product was not meeting a certain standard. So think a widget had a defect. We could easily remove it from the floor and it was gone. But you can't do that in healthcare delivery because the product is not a tangible item. So things change a lot. So we had to change our view, not only because of the product, which is health, but also because of the consumer, of the customer, because we have a feedback loop even with the customers. Does that kind of sound like you guys understand that the patient is considered the customer, but it's not just the patient. So we're going to show this next. Go ahead, Talat.
Yeah, so like you were discussing, so in this scenario, the product would be the outcome?
Yes, yes. Okay. So when you think about, why are people popping in and out of the waiting room? We're having connectivity issues. Oh, that rain. So when you think about health, and we talked about this a while ago, when we think about the production of health, so in management or just in general in healthcare delivery, remember that we are producing, it's a service, but we're not producing a product. We don't make a car. We don't make we don't make something in a package that you can unwrap and take home. We produce health, right? The outcome is health. And usually that health or that outcome doesn't match the input. It's very different. So maybe the doctors put a lot of time, you take a lot of medicine, but you still have a chronic disease, or you put very little effort, but you come out just fine with a cast and then you're fine in 6 months or 6 weeks or whatever happens, right? That is what makes healthcare delivery and health a complex adaptive system, because the complexity of the care has an input that doesn't necessarily match the output, right? So when we think about a linear system, right, 1-to-1, if I give you $1, I expect $1 of value. So if I give you $1 at the grocery store, I expect like $1 worth of groceries. If I give you $10, I expect $10 worth of groceries. In healthcare, sometimes I'll give you $1 and I'll get $10 worth of health. Sometimes I'll give you $100 and I get $1 worth of health. But that's because of many factors. So that is something that makes healthcare delivery very complex. And that's why quality assurance is an old way of thinking. And really, it's not old, it's a standardized or managerial or scientific management way of thinking. If you guys remember way early in our theoretical slides, right? Very rigorous closed system, right? Which assumes no humans, that we can standardize everything. That's not the case in real life. So let me get back to the two customers. Who are the two customers in healthcare delivery before I jump in? Because then it'll be really obvious. Oh, okay, I'll show you. Anybody guess? Besides the patient, who else is the other customer?
The provider.
Oh, dang it. Yes. I thought it was going to be harder than that. Yes, exactly. Not just the provider. You are the customer. The staff, the employee, the member of the organization. You are the other customer. So when you look at these feedback loops, when you first look at this, you're like, what in the heck is this thing? But I want you to look at it in terms of who is who in what moment. I know this looks a little confusing, but think of it in terms of who is adding value when. So when the patient is the customer, right? The customer-supplier relationship, the supplier is you, right? Then you add value to that patient's visit by ensuring that they have a great visit, that all of their paperwork is in order, that the environment is safe, that their care is correct, that the right side of their surgery is occurring on the side that it's supposed to occur. I don't know, I'm trying to think of what other transactional elements, that their food is arriving, if they're inpatients, that, et cetera, right? And that's the outcome. So that's that loop that we have in terms of the customer. When you're the customer, who adds value to who's your supplier? Who adds value to your experience?
The service?
What does that mean?
And like your interactions with your physicians, nurses, the
Okay.
access to what you need.
Okay. And who else?
And whoever is above us, in hierarchy.
Exactly. So what's important about this? I don't care if you memorize this. What's important is you must know when you are adding value, when you are providing value, when you are the customer, when you are when you are the supplier. I'm like, wait, not the customer, when you are the supplier. And the reason that that helps is that when you see your perspective, it also helps you speak up and recognize, from what perspective am I operating here? From what perspective am I planning? Am I organizing? Am I communicating? Does that kind of make sense as to why we need to think of the who's the customer, who's the supplier relationship? Because you are also, your role needs value to add value. So if you don't know, if you're not getting value in your role, how can you pay it forward into other roles and vice versa? Okay, so moving on. And then I stuck with CQI because I care about the continuous part. I'm really big on the feedback loop. Other hospitals, like I said, with our motto, if you've seen one, you've seen one. But I stuck with the continuous part because, like I said, that feedback loop is super critical, and you'll see why in just a minute. For me, and from the perspective of management that I take, because I treat healthcare delivery as a complex adaptive system, meaning that we never know the full extent of the input to the output. It's not just the responsibility of one individual, because a patient could be in one department, but they're going to have interactions with multiple people across the service line. They're going to have interactions with people at the front door. They're going to have interactions with people in billing. They're going to have interactions with everybody. So the organization needs to take that into account. And again, for the second element, that is about the customer and double customer role. So not just the patient, but also you, and not just you, but also the clinicians, but not just the clinicians, but also the support staff, not just the support staff, the nurses, environmental, everybody is a customer. Okay. Yes, everybody. Oh, and here's the word soup I was showing you, which I hate. So that's why I show it to you, because I hate it. They're all synonymous. It drives me crazy. But essentially, and when you think about the definition of the organization, I want you to think about these essential elements. It's organization-wide, meaning it's bounded. It's process-focused, meaning that you have goals, right? The organization has goals. An organization, when I think about definition, is a bounded, goal-oriented entity of socialization. So if you look at this is exactly the definition of an organization, but it's a dynamic definition of an organization, I would suggest. Does that kind of make sense? How CQI and I think it matches better with the definition of an organization. So the questions that you ask yourself when you're thinking about continuous quality improvement, that feedback loop I go on and on about, are how can we be certain that we're doing things right the first time, every time? And within that is process improvement. And that's most of what you guys will all be doing. So if you get anything from here, it's line 2. Forget everything else. Focus on line 2. Are we doing things right? Okay. So you guys, as you're beginning, you're going to be asked, are you doing things right? Meaning, is whatever goal that has been set for you, because you're going to be new, are you actually measuring that goal? That's process improvement. You understand? So you're going to be told about a process. Here's a process. Why isn't it working? So you're going to be saying, why aren't we doing this right? That's basically your life when you're first starting out. Now, as you grow and you become more experienced, you're going to start saying, are we doing the right things? I mean, we're doing things right, but are these the right things? And I know it probably sounds like I'm saying the same thing, but read through them and chew on them a little bit, okay? Can you kind of see the difference? So for example, a really good example is physician incentives. But physician incentives and hospital incentives are starting to be found to be not quite fully aligned with patient outcomes. They're perfectly measured. So we're doing things right in how we measure them and and we're doing things right and making sure that we have these incentives, but are they the right things for patient outcomes? That's up in the air. TBD. So here is another image that might be helpful. It's kind of, can you guys see it okay? I don't know if you can see it okay. So you can see here, continuous quality improvement. Here's the question: how can we be certain that we do things right the first time, every time? And then we have process improvement. Are we doing things right? And then are we doing the right things? And then you have the whole element, the whole true improvement. And true continuous quality improvement actually does enhance not only retention, job satisfaction for your employees, forget productivity, I don't acknowledge that, and competitive position. So that's what you really want to think about when you're thinking about continuous quality improvement, okay? Does that kind of make sense? So when you're starting out as a brand new baby healthcare manager, you're gonna always probably be thinking about process improvement. You're not likely gonna be thinking as much about are we doing the right things just yet, because there's a much broader strategic element to that you're gonna learn about. Now, you do have the opportunity with your internships, hence me pushing you, to see other people asking these questions, to see other executives answering, are we doing the right things? You can ask them, how do you know you're doing the right things? Like, I can see that you're doing things right. You're measuring the processes you have with Lean Six Sigma. Oh, you're within one standard deviation. That's perfect. You're perfect. But how do you know those are the right things to do? Ask. There's nothing wrong with asking. And that's how you can learn and expose yourself to that so that you in the future can also be making those decisions. Does that kind of make sense? Everybody with me? I know I kind of lost you a little at the beginning. Sorry about that. But does that kind of help in terms of how that works? Yes, no, little? So I will tell you this about process improvement before we get into more history, because I do have 2 history sections. I couldn't help myself, I'm sorry. One is that it requires that moon thinking. It requires negotiation. It is very complex. You can spend a lot of time becoming better at process improvement. Anybody that has ever done a group project will have participated in process improvement. Because if you've ever been in a meeting where you got nothing done, you will know how to identify opportunities for improvement, AKA process improvement, OFIs. You heard me say OFIs, OFIs, OFIs. And you'll know what can go wrong and what can go right. Because you'll say, oh, that was a very productive meeting, or that was a very productive class, right? Because information was transmitted and understanding was gained, and then actions or next steps were clearly transmitted. But a lot of it has to do with communication, definitions, and encouragement. And that's process, and the process mapping that we're going to do today. Excuse me, sorry. Okay. So I'm going to skip the pioneers, but you have to read them because they're amazing, please. In case you ever wondered where Listerine came from and why we wash our hands. I just want you to know that it's pretty amazing stuff. I know, it's laughing up. But also we're going to just talk about Shewhart. So Dr. Shewhart was an American statistician, and he developed the basic theories of statistical process control, which you'll learn about hopefully in the fall, because we don't have time to do it here, and the plan, do, study, act cycle, which is the methodological core of CQI and everything else that you know. So that is who Dr. Shewhart was, and he's up there with all of these other guys, okay? So just a quick, here is Florence Nightingale's, the first pie chart, in case you're wondering. Tiffany, I see you smiling. I'm sure nurses have heard of Nurse Nightingale. And this is the Shewhart cycle. The Shewhart cycle is going to influence so many of the CQI activities that you do, the lean activities, the Six Sigma activities. And you may have heard of Plan, Do, Study Act or Plan, Do, Check Act. This is fun because this was a little bit of an ESL thing that was lost in translation. when it was going into the Kaizen planning elements. And so this was, but it's all the same. And this, the Shewhart cycle also inspires statistical process control, which I'll cover next week if we don't get to it this week. So I'm going to stop right here because I want you guys to, we'll continue this part next week because I want you guys to see the process mapping that I'm first talking about, because to first identify those OFEs, right? So when we look at this PDSA cycle, when we're thinking about learning and improvement, we need to be able to see what the problems are, right? But we need to know that, first of all, especially with healthcare, things don't happen in a vacuum. We know that it happens with a lot of people. So I'm going to stop sharing for just a second. And I'm going to show you, can you guys still hear me? I don't know why I thought you can't hear me when I stopped sharing.
Yes, we can.
I'm going to show you just a very instructional video to get you started for your homework. And hopefully, give me 1 second. Okay, so hopefully I'm going to share again, and you can see this very, very informative video about how we begin to map a process. So, and this is going to be the premise, but just to get you started, the first element of process mapping is visualizing. So when we think about process improvement, we first need to identify our process, right? So remember when we talked about problem solving and decision making, we have to identify our problem, right? So with a process, just like a case, so we see how we're making the transition into the active field, there's going to be many problems. Or in the case, some cases there's very few, but we need to identify those. I call them OFEs, opportunities for improvement. We can call them problems, or we can call them OFEs. I prefer OFEs. This is a little more positive. But we can, I taught my son OFEs. It's kind of fun. Then he still complains. It sounds really positive. He hates it. So we can have those OFEs, and then we can learn to prioritize them, right? So we have our list on the moon. We're saying which one needs to be addressed first, even within costs or whatever a person is passionate about too. There could be an intersection right there, right? Or what aligns with the strategic plan. But first we need to see it. We need to see the plan. And so the first thing you do is you want to identify that, and you want to see the goal in mind. You want to start your process mapping with the goal in mind. So I've offered this little video. It's in your Canvas too, but I'm going to share it with you. I don't know if I can actually play a YouTube video, so I'm hoping I can. Can everybody see this?
Yep.
You can. Can you hear it? Can you hear it or no?
I think before you start share screening, you have to enable computer sound for us to hear the video.
Oh no, that's not what I want. How do I enable sound? Same as system? Dell? Like, I'll try that. How's it? No?
So if you stop share screening and then click share screen again, and that box pops up with like all the different screens you can select, there's a little checkbox at the bottom that will say share computer sound, and you have to check that every time.
Found it. You're the best.
Sheldon, there is no algorithm for making friends.
Hear him out. If he's really onto something, we could open a booth
Yes,
at
no?
Comic-Con, make a fortune.
I'm gonna start it over.
time. I believe I've isolated the algorithm for making friends.
Sheldon, there is no algorithm for making friends.
Well, hear him out. If he's really onto something, we could open a booth at Comic-Con, make a fortune.
See, my initial approach to Kripke had the same deficiencies as those that plagued Stu the Cockatoo when he was new at the zoo.
Stu the Cockatoo?
Yes, he's new at the zoo.
It's a terrific book. I've distilled its essence into a simple flowchart that will guide me through the process.
Have you thought about putting him in a crate while you're out of the apartment?
Hello, Kripke. Yeah, Sheldon Cooper here. It occurred to me that you hadn't returned any of my calls because I hadn't offered any concrete suggestions for pursuing our friendship. Yeah, perhaps the two of us might share a meal together. Yeah, I see. Well, then perhaps you'd have time for a hot beverage. Popular choices include tea, coffee, cocoa. I see. No, wait, don't hang up yet. But what about a recreational activity? I bet we share some common interests. Tell me an interest of yours. Really? On actual horses? Tell me another interest of yours. Oh, no, I'm sorry. I have no desire to get in the water till I absolutely have to. Tell me another interest of yours.
Uh-oh, he's stuck in an infinite loop.
I can fix it.
It's interesting, but isn't ventriloquism by definition a solo activity? Yeah. Tell me another interest of yours. Is there any chance you like monkeys? Yeah, what is wrong with you? Everybody likes monkeys. Hang on, Kripke. A loop counter and an escape to the least objectionable activity. Howard, that's brilliant. I'm surprised you saw that.
Gee, why can't Sheldon make friends?
All right, Kripke, that last interest strikes me as the least objectionable, and I would like to propose that we do that together. Tomorrow. Yes, I'll pay. All right, goodbye. All right. Time to learn rock climbing.
All right. So, very quickly, because I know everybody has to get off, and I'm always, as usual, exceeded. So, was everybody able to view that successfully, hopefully? So, first of all, what was the goal of that process or flowchart?
Go out with Kripke.
Close.
Make friends.
Yes. Make a friend, yes, or develop a friendship. But yes, which is with Kripke, so that was his target. Because he could have applied it to other people, right? So that's why it's not specific, but that's the goal, right? And then, did everybody understand the feedback loop element? So that's that continuous quality element, which is not necessarily continuous quality. It could just be things that happen within a process, especially when there's a caveat, when there's something that happens, a barrier that can cause that feedback loop, right? So you can start to see where there's decisions, there's choices that can change how we approach a process. And one of the other important elements of a process is that when we begin to think about process improvement, we must first always map the process that is, meaning that we're going to see the process that is as it is, right? So the reality, so what we observe, which is not ideal, right? And then we also need to map, and you can do these interchangeably, but then we also map the process that we wish we could see, the ideal, what should be happening. And then when you get really good at it, you just map one and identify the OPs. But otherwise, if you don't map both, then you can't see what the problem is. And you might be good enough that you do both, right? So this is what should not be happening. Does that make sense? But you always have to map what is, the reality of what is, to demonstrate to the people involved, because what else does a process map or flowchart show us? Which may not be part of the video. It shows us everyone that's involved, right? It shows us, oh, the emergency room doctor is here. And that's your homework, actually, is the emergency room doctor in the emergency room. so-and-so is here. Oh, this actually includes a certain other person that I hadn't even thought of. Oh, this actually includes a transfer that we didn't take into account. So that's the other high value element of process mapping, is that it helps you recognize where there's value in showing, hey, look at all the other people involved in the process. So it shows you the perspective and what priorities they might have. And it also allows the other people to see, oh, wow, you know, the nurse is doing everything. I probably need to participate in this process more, or be more vocal or communicate more, because I didn't realize that, in fact, I'm very lax about my role in this process, and I could probably do more. Does that kind of make sense? Why these process maps are so invaluable? And I will tell you that these process maps that I've taught these students have gone into practice immediately. One of your fellow colleagues put these process maps into practice in the COVID command center for vaccine throughput. So just FYI, this is something that you can immediately use. Like, I'm not kidding, immediately use. So with that said, your homework does involve mapping a process for which I give you a case. And you have a lot of time to do it. So we can talk about it more next week, but I wanted to make sure you knew that it has dropped and it is on your module, even though I know that you guys have questions about take-home quiz too. So I'm going to stop recording now, and then I'm going to start a new recording so we can talk about the take-home quiz. Okay?